Welcome to the Natural Health Podcast, where we bring awareness of sustainable health in the business hustle space. Natural Health Podcast is perfect for the high-performing, business-minded individuals who want to work with their biochemistry to achieve success and optimal health. It's Friday, which means it's time for friends sharing facts about health, business, and overall success. In today's episode, we talk to Dr. Dave Shirazi. Dr. Shirazi graduated from Howard University College of Dentistry in Washington, D.C. in 2000 and earned a master's degree in Oriental Medicine from SAMRA University in 2006. He's also a broad licensed acupuncturist. He's completed over 2,000 hours of continuing education in TMD and facial pain and sleep disordered breathing. He's also completed a hospital mini residency in Oriental Medicine at the China Beijing International Acupuncture Training Center, which is the only organization at the World Health Organization has authorized to teach internationally on acupuncture and herbiology, and another at Kairung He University and Medical Center, the top medical hospital and medical research school in Korea. In 2011 through 2016, he became a broad licensed RPSGT, the first and so far only dual degree dentist and RPSGT. He's the founder of the Bite and Breathe and Balance podcast, dedicated to the multidisciplinary approach to treating craniofacial pain and sleep disorders in adults and children. Dr. Shirazi is the director of state-of-the-art private practice, the TMJ and Sleep Therapy Center of Conjo Valley and LA, that are limited to the treatment of TMD, craniofacial pain, sleep breathing disorders, and craniomandibular orthopedics.
Orthopedics. We'll be here all day.
Practice.
Let's get on with it, please. I'm bored with myself already. Enough.
Well, welcome to the Natural Health Podcast. And Dr. Dave, we've had you before on this podcast. If anyone wants to listen to your intro, we can listen to it on there. And then we spoke about sleep, and that was episode 241. But let's get and talk about today's absolutely exciting topic. What we're going to be talking about is you have sleep apnea and you just don't know it yet. Sleep apnea. I know we spoke a little bit about it last time that you were here. Are we able to touch base a little bit on it so we can get the audience a bit of an outline of what it is?
Yeah, so we measure sleep apnea as when we hold our breath for 10 seconds or greater, and or we have shallow breathing that causes 3% oxygen desaturation or more. And what I think is probably the most salient component of sleep is what's called an arousal, right? An arousal is when we get kicked out of a deeper stage of sleep, like delta or REM, into a lighter stage of sleep, like 1 or 2. And it can happen from something in our airway that's not a total blockage of airway for 10 seconds or greater, or an oxygen desaturation at all. We can have a like one of those little like snorting events that'll kick us out of that arousal state for 10 seconds or more. And that will be associated to all the inflammatory problems that can come from sleep apnea.
And is that due to the people, how they were born like that? Is it due to a structure in their throat, in their neck, their tongue?
It's rarely genetic. Predominantly, they'll say, you either have a small airway, you have poor nasal passages. But the reason we don't say it's genetic, those of us who are educated, is because when we look at skulls prior to the Industrial Revolution, they all had very wide palates, very big nostrils that they were able to shift a large volume of air. They had a lot of room for their tongues, and they had a lot of girth to their jaws, because as soon as they got teeth, they were given food, hard food to chew, which all that muscular activity gives us what's called vertical dimension. Yeah. So it's pretty intense. So modern man, we eat a very soft diet. We don't breastfeed largely, and we know breastfeed is associated with the development of our arches. We get these giant sinuses and this little teeny nose space, all of which is conducive to sleep apnea. Many of us consider SIDS, that childhood disease called sudden infant death syndrome. We consider that as pediatric sleep apnea or infantile sleep apnea. It can be.
Wow. And what would the link be there? The kid doesn't get enough oxygen.
Well, there's something. So for example, one of the reasons we have symptoms of sleep apnea is when the muscular tone in our upper pharyngeal and tongue space is very weak. So the basal tone is weak, and so it flops and closes, right? An infant doesn't have very much muscle tone here. They just have swallowing muscles. That's about it. And if they get a low-grade infection, they can get enlarged tonsils or enlarged adenoids, which will then interfere with their breathing. But then they don't have enough muscle tone to resist the collapsing of their airway, and they can choke in their sleep. It's extremely tragic.
100%. So sleep apnea doesn't discriminate against age. Not only just people over the age of 50 have it.
No, in fact, if anything. So for adult white males, we say if you have 5 events or less, that's considered well within normal limits.
Is that per hour, per day? Yeah.
Per hour. Sorry, I should have said that, per hour. If an infant or even toddler has 5 events an hour, that's considered very severe, right? The reason being is, remember we talked about the REM and the delta, right? So in adults, we have 25% REM, 25% delta, and the other 50% is stage 1 and 2 in varying degrees, right? An infant, a brand new infant, has about 99% delta and REM, right? And it starts to slowly wane. You start to get less delta, you start to get less REM.
That's absolutely crazy. So anyone can have sleep apnea, no matter what the age is, no matter what sex you are,
and your BMI. And your BMI. Yeah, they did a study on college-aged females with a BMI of 19 or less, which means thin. They did a sleep study on them, and 50% tested positive for sleep apnea.
So it's not even your BMI, it's not your age. So what causes it? What are the main culprits of causing sleep apnea? If it's not your age, if it's not your BMI, what is it?
Well, the BMI does play a role. Being overweight will compound whatever you have. So, for example, if you had, let's say at the age of 30, you never had any apnea, but you had a little bit of snoring, you had a sleep study showed just snoring. And then that same year, because of COVID restrictions, you stayed home and you became a fatty boombalatti, right? Then you gained like 20 pounds, 30 pounds. Then you can have full-blown sleep apnea, right? Because the sleep apnea made the snoring worse, right? Or if you already had sleep apnea, you had like an AHI of like 15, and then you go ahead and pack on 20, 30 pounds, which is what, like 15 kilos, 12 to 15 kilos. If you pack that on, then you could go from 15 to 30, right? So, and if you go to 15 to 30, you've gone to the high end of mild to the low end of severe as an adult. So it's significant. The weight is significant, and it can be causative, but the majority of the time, it's the lack of muscle tone and the amount of nasal airway we have. The nasal airway is a huge component.
So the muscle tone, right? We mentioned back about being breastfed. That helps our muscle tone.
Absolutely.
What else helps our muscle tone or reduces that muscle tone?
Well, we reduce the muscle tone basically from atrophy, right? So if we don't use it, we lose it, right? And I think I mentioned last time that there's been a number of studies in Australia with the didgeridoo, which people that had apnea and then learned the didgeridoo and then did a follow-up sleep study, it reduced their sleep apnea by 50%. Right across the board.
That's crazy, but playing a didgeridoo.
Yeah, because it's actually very hard. I bought 2 didgeridoos when I was in Australia, and I got the good, sound going, but you have to do circular breathing, right? Which means you have to keep your airway taut. Inhale while you're exhaling. Inhale while you're exhaling, which takes a lot of muscle tone.
That's so interesting. That's absolutely amazing. So most people will say, I don't really have sleep apnea because I'm not snoring, because for some reason we've all linked snoring to sleep apnea. Yeah. So does it mean that if you're snoring, you have sleep apnea 100%, and if you're not snoring, you don't have it?
No.
Let's clear out that picture.
Yeah, I mean, I would say, I think the numbers reflect that 70% of people that snore have sleep apnea. So it's more than half, almost 3/4. But no, you can have just the snoring and cause that. Now, and actually a huge study came out of Australia, which I think they looked at 9,000 nurses, right? And they just had snoring with no apnea. And if I don't want to give you the wrong quote, but one study with these nurses showed depression with their snoring, and another one showed risk of heart attack, right? Their elevated risk of heart attack from presumably the arousals from snoring.
Yeah. So essentially, how much do you know a percentage of individuals that have sleep apnea and actually don't know they have it? Someone might be listening to this episode.
Majority.
Yeah.
The vast majority, I would say 90% at least of the people that have it haven't been diagnosed with it and don't know they have it.
Wow. That is a lot of individuals. It
is a bit, I mean, especially in America, I know you guys have a growing fatty boombalati population, but we have a large fatty boombalati population, myself being one of them. And it's a pretty common problem, out here, being overweight, and it's just not talked about. I think I may have mentioned it last time. I was a child. I'm sure I had sleep apnea. I had bedwetting, I had ADD, I had hyperactivity, and my mom was a dentist. She's still a dentist. My dad was a pharmacist, and we didn't know. That was 40 years ago. We didn't know. And, even today, it's not very common. I actually went to an amazing conference in San Diego, and there was a wonderful, amazing orthodontist researcher. I don't remember if he was from BU or from Harvard. And he gave an interesting presentation. And I went up to the podium to ask a question. And I said, I'm sorry, my first question is political. He goes, go ahead. I said, how much research is enough research, right? I've been doing this kind of functional orthodontics that we now know can cure, not treat, cure sleep apnea in children. When will these people either change, retire, or die so that, the world can move on, right? And a number of people in the room were laughing at my comments, and he himself was like, wow. And I said, I'm sorry if it sounds harsh, but there is blood on their hands. There are a number of children not being treated and are suffering severe quality of life issues because the people that are dictating what the norm in orthodontics is are not properly addressing sleep apnea, right? And it's shameful. And all he could tell me is that, paradigms take a long time to change, and that, younger blood is coming in, and, things are changing, but it's going to take a while to show it.
So what do you do? How do you know if a kid has sleep apnea?
Well, the first thing, I'm just going to tell you now, the only way you can know or not know you have sleep apnea is if you do a sleep study. There's no way. That's another thing. It's like an X-ray is not diagnostic of sleep apnea. Snoring is not diagnostic. I would be gravely concerned if their mouth was open, right, when they slept. I would be very concerned about that.
And that's for adults too, not just kids, or for anyone. If your mouth is open when you're sleeping, that's an issue.
Absolutely.
The only time your mouth should be open is when we're talking, or we should be breathing through. Like you said in our last podcast, you mentioned about the importance of nose breathing.
Yep, we're supposed to be exclusively nasal breathing.
That's huge, exclusively nasal breathing, because you don't hear that from a lot of people. A lot of people don't say that.
Yeah, I know.
Exclusively nasal breathing.
Yeah, I mean, like thought leaders like Patrick McEwen and, ENTs that understand the function of the nose do say it. But, again, paradigms, it takes a long time for paradigms to change, and it's very, very difficult, right? And, we can have a change in the paradigm without making it a horrific thing for the way it was before. What we cannot have is people rejecting new paradigms because they're fervently attached to their old paradigm, right? It's one thing, if I can get technical, it's one thing to say, okay, well, I'm going to go ahead, my methodology is to give vitamin C to help people with cold and flu-like symptoms. Okay, great. And then someone with a new paradigm says, well, forget vitamin C, that's expensive. Let's just give them these RNA injections, and that'll give them lifelong immunity to anything to do with cold and flu. It's like, okay, so both sides should not reject each other. They should say, okay, well, show us the evidence, okay? And it's going to take time, right? Because if you're giving something that's very artificial, then you have to look not just for the short-term side effects, but the long-term side effects, right? With something like functional orthodontics, where we expand the palate, bring the jaw forward, and et cetera, we take cases of people who are very crowded, expand their palate, and now we've got all kinds of space for all their teeth, right? So it's not like we're telling them, we're asking you to change your paradigm into something that's wild and radical, and we don't know what's going to happen. It's like, no, this was the original orthodontics that Dr. Engel was doing 100 years ago, okay? It prevents the need for extraction. And now we're finding that it expands nasal breathing and can prevent and cure sleep apnea. So we already know from history what the side effects of palatal expansion are, right? We don't need your input, okay? What we need is the greater understanding that functional orthodontics, palatal expansion, bringing the jaw forward, has an opportunity to be a new paradigm to avoid surgery and unnecessary root amputation, and then therefore possibly treat and cure sleep apnea in children, right?
And so that's by expanding the jaw.
Yes, both. The thing is, there's no justification for skepticism, right? So right off the bat, skepticism is not scientific, right? In medical school, they're taught that skepticism is good. That if you're skeptical, you're sitting there and you're a very discerning doctor. You're set in your ways and you're not going to let them change your mind with bullshit fads. Like that's what they think. That's what they think. But what skepticism is confirmation bias. You're basically saying you're prejudging something in a negative light before you have the data, right? That is not science. That's the opposite of being scientific, right? Scientific would be, well, I don't know, right? Or we have data, but we don't have a lot of data. Or we don't have multi-center studies, or long-term studies, or just empirical data points, right? Like that would be scientific to say that, right? But to out and out reject a methodology when the evidence is there to support it is just bias, and it's a horrendous disservice to the public.
And it doesn't help anyone.
It doesn't help anybody. It doesn't help anybody.
100%. You were talking about widening the jaw, the palate.
That's right.
So is that a surgery, and can you do that at any age?
So conventional orthodontics says you can't do it after a certain age, like 18 to 20. We know that they are wrong. I just want to be clear. With rare exceptions, you can expand in an adult. My philosophy since I learned orthodontics 20 years ago has been to go low and slow, low force over time. Yeah. And we know that we get less relapse when we do that. When we have rapid palatal expansion, we get it done in just a matter of months, but we have like a 30 to 33% relapse rate, which is ridiculous, right? And then plus we split the suture in the palate and we cause bleeding. Again, it's unnecessary, right? And they do argue that, well, look at how much more air volume you're getting, right, in the nose when you go strong in the palate. But the thing is, and the data is being compiled now, as of this podcast, I don't know research that shows this. So like for every 1% that we expand, we get 4% increase in airflow, which is huge, right? Now, the things that we don't talk about is when we go low and slow on the expansion, we don't just expand, we drop the palate. We make the palate more flat, which means in addition to the width of the nose on the inside, we're also getting an increase in height. Okay. And that is cubed throughout the airway because the nasal space is like 3-4 inches deep, right? So I don't know what that is in millimeters, forgive me. So the benefits are going to be huge. It's just a matter of I don't understand why the paradigms are taking so long.
100%. The other thing that I was also going to say is the fact that, yes, you can do that on kids, which is amazing. But you said at the start of the podcast, you said that that's how we used to be. We used to have bigger nostrils, wider jaw, palate, and so forth, more jawline. But when we look at now how things are going with plastic surgery and actors, actresses, models, and so forth, they're all pulling back their chin. They're all making their nose smaller. This isn't beneficial for breathing. Is this right?
Well, that's the question. There was this Facebook group with 300,000 plus members in the LA area. And someone, I'm very cheeky, as you can tell. Someone had made a request. She goes, "Oh, does anyone recommend a plastic surgeon? I'm thinking about getting some work done." So most people were like, "Oh, you can go see so-and-so. I like so-and-so. This person changed my life." And other people are like, "Oh, you don't need it," whatever. So I just chimed in and said, "Haven't you looked around and noticed that they haven't got it figured out yet?" And there is a bit of truth to that because it was meant to be a joke, but the truth in that is there's making you look a little bit younger, less wrinkly, more tight, things like that. And then there's making you look how no other human being looks naturally. And being in LA, we actually do see a lot of people who get, the baboon lips, the baboon butt lips. And, their eyebrows are like damn near touching their hairline. And they think they look attractive. I don't know if it's because of the Instagram, influencers or not. I don't understand. I don't know what they look like before. So I'm certainly not in a place to judge. And it's their body. They can do whatever they wish to it. I just know, being a dentist and looking at people's faces all day, I cannot stop to look. I just stare. Like I can't, I like to make eye contact with people, but I can't help but stare into their baboon lips and just like, it just looks so off
But I mean,
Because I don't know anyone that looks like that.
it would have an effect on them breathing, right? It
depends how it's done. Some ENTs have cross training in sleep apnea, airway, and facial plastics, and others are just about facial plastics. That's all they care about.
Yeah.
So it depends. I know we have a great selection of great ENTs in this country, and I'm sure you do too.
Yeah.
I don't know. Are there people getting surgeries to pull their jaws back? I've seen the other way.
Yes, I know a few individuals, yes, that have pulled their jaws back. Here. Yes, I do. And I guess that would impact their breathing, if it depends who it's done by, like you said, or it may even impact their sleep, in a sense that, it'd be interesting to talk to someone and see what has changed from changing their structure, if it's had any impact.
So when I first started out, I met a dentist, and he had what's called class 3. That's when you have an underbite, when your jaw is forward like that.
Yep.
And he wanted to do something about it. So he talked to the oral surgeon. They went back and forth. They're like, okay, we're going to do this on you. We're going to do that on you. You got to wear braces, this and that. He did the surgery. Everything went fine. When you wake up, they take the tube out of your throat, and he couldn't breathe. So literally, he couldn't breathe. When they broke his jaw and set it back, they closed up the airway. Right? And this was a major obviously, this was a major problem. So nowadays, especially for men, if someone has an underbite and they're going into surgery, rather than bring the jaw back, they'll bring their upper jaw forward, which not only looks more natural, but it's better for their airway.
That's so interesting. I'm getting ready for this podcast, and I've already previously made the link between fatty liver and sleep apnea. There's a lot of research showing that fatty liver and sleep apnea are directly linked to each other. What are your thoughts on that?
I haven't seen any studies on that. Okay. I wouldn't be surprised, but I would come back to the inflammation, right? The liver is a detoxing organ. And if you're constantly inflamed, it's trying to help you with your inflammation. The purpose, inflammation has a good purpose. Inflammation is to repair and to grow. Okay. But when you don't have anything to repair and you don't have anything to grow because you're an adult, then inflammation starts breaking you down. Right. So that affects all systems. I don't know anything that isn't negatively impacted by inflammation. When you're not healing and repairing. So, like, for example, I don't know if last time we talked about it, the incidence of depression and anxiety with sleep apnea.
We can touch upon that. Yeah, let's do it.
Yeah. So we've done large studies, not even small, where we've seen that the correlation between depression and the correlation between sleep apnea in the same individuals is 1-to-1, meaning the more severe their depression, the more severe their apnea. We see patients that have both anxiety and sleep apnea, and once their apnea is treated with either CPAP or oral appliance therapy, their anxiety either goes away or is greatly improved. Right? So we're seeing this. We know it happens in real time. Right? So the information is there. It's just not mainstream yet.
You're 100% right. 100% right. So in regards to sleep apnea and metabolic disorders, because metabolic disorders is a huge issue here in Australia, type 1, type 2 diabetes, and so forth, metabolic issues. And that's directly linked to not sleeping well, and yet alone sleep apnea. What's your view on the whole metabolic disorders and sleep apnea?
Yeah, it's kind of the elephant in the room. It's the elephant in the room. So we know that when you have sleep apnea, you get hungrier because your ghrelin is increased. We know your metabolism is altered because you're staying in a more fight or flight mode. So your body isn't digesting, right? It's of course, I mean, it is embarrassing. I mean, we called it Syndrome X for like the longest time. And it's like, really, is it that hard to put them all together? Is it that challenging to find a universal thing going on? So they did a study, a case study. I'm sure you've heard of 60 Minutes. When they were an honest organization, when they were a good journalistic integrity video reporting, and they were, up until recently, they were excellent. I mean, they've been going on for decades. They've been a wonderful, reliable, honest source of journalism for decades. But I would think in the last 5 years, forget it. They've been horrible and biased. But they did a case study with a healthy young man. And what they did was they took this kid, he was an athlete. They did a sleep study on him. No apnea, no sleep problems, sleeps perfect. Did a blood test on him. All his blood labs were normal. Okay. Then what they did was they kept him in the hospital for a week, and they did sleep studies on him every night. And they waited for him to get into deep stages of sleep. And they rang a bell, right? And they rang it just enough to kick him out of the deep stage of sleep into a lighter stage of sleep, but not wake up, right? So he woke up, he felt fine, right? That's another indication when men and postmenopausal women with sleep apnea will wake up feeling fine, right? We believe it's the testosterone, but we don't know for sure. And then towards the end of the day, 4 o'clock, 5 o'clock in the afternoon, they'll have a bit of a crash, right? They'll want to get some caffeine. They'll want to get some Red Bull. They'll want to get some sweets just to carry them over until bedtime. So in his case, that's, mind you, that's all they did. For a week, they interrupted his sleep, right? And throughout the time, he kept asking for more food, right? And they asked him, I go, so do you think you're eating the same, more or less? He goes, I'm eating exactly the same, right? Because he never weighed his food before. He just went, oh, I'm going to eat. When I'm full, I'm going to stop eating, right? And he kept doing that, but he wanted more food. He was hungrier. He didn't know, right? And he was sedentary. He was sitting in the hotel, in the hospital doing nothing. So after a week, they did blood labs on him again, and he was pre-diabetic. His liver enzymes were up, and his blood pressure went up a little bit. So we have to sit back and go, if that can happen to a super healthy, virile young man with only a week of interrupted sleep, not even apnea, just interrupted sleep, what will that do to a 40-year-old? Right? Now, the other thing we know is that women of childbearing age are more sensitive to the arousals, right? So for example, children are obviously the most sensitive. After children, it's the female population, right? Of childbearing age, I should say. The postmenopausal women and the men, by and large, respond the same, to sleep apnea. And that's the part that's kind of sinister, is whereas before, when I talked about how men with an AHI of 5 or less will be considered within normal limits, they've correlated women with an AHI of 4 with migraines, TMJ disorders, fibromyalgia, and a litany of other issues.
Wow.
Right? So we know that estrogen sensitizes pain, and it also makes us more sensitive to being woken up.
That is going back to that study, you said only 1 week of disrupted sleep, not even like you said, of a healthy individual. And then they did blood markers, and like we mentioned, their liver enzymes were through the roof, their glucose was
Not through the roof. They went up. Like, so he wasn't diabetic, he was pre-diabetic. His liver enzymes went up when they were otherwise perfectly normal. Blood pressure went up when they were perfectly normal.
So imagine an individual that already had high glucose or liver. That is definitely some damage right there to their health.
For sure. For sure.
It's absolutely extraordinary. I mean, individuals who are listening and are like, oh, maybe that sleep apnea doesn't affect me that much. I'm not too sure if I have it. Well, it does. Like Dave just said, it impacts you, even if you're really healthy and then you get sleep apnea. And you said a sleep study is needed to determine it, right? Is that an at-home sleep study, or is that in a lab, or?
Either one. Either one. I'm very open to doing in-home studies. I'm not against it. Generally speaking, what I tell my patients when they say, which one should I have? I just came back. It was my birthday, so I didn't get as much sleep as I should have. First of all, if you're testing for insomnia, you really should be in lab, because that's where we're going to put the EEG sensor so we can look at your brainwaves. But that's not terribly common in a sleep study. If you're snoring or you choke and you want to go get tested for sleep apnea, what I tell people is, when you go on holiday and you're staying in a hotel, can you put your head to the pillow that first night and go to sleep? Or does it take you a little while to get used to your new environment, like a day or two, right? And most people say, it takes me a day or two to get used to that bed, the pillow, all of that stuff, right? Well, I tell them, in that case, you should do the home sleep test, because you're going to get a slightly altered in-lab study. But if they say, you know what, doc, I am so tired, I put my head to my pillow, I am out. And I joke around with my wife that my wife has a PhD in sleeping. She can drink 2 cups of coffee and sleep on a bed of nails on her face. These people will do fine in a sleep study. In fact, that's what we did. We did a sleep study on my wife while she was pregnant. She had no problem getting used to all the leads and all of that, because she can sleep on at a drop of a hat.
Yeah, so it just depends on the individual. So are you able to run us through maybe a successful result if someone's come to you with sleep apnea? What was done? And like, if someone came and said, can you give us an example of a success story?
Well, if you go to YouTube, I have about 30 testimonial videos from patients and doctors that have shared their experience. My favorite is a patient I had a very long time ago. Her name was Barbara, right? And her story is so perfect. She had depression, and she was fatigued, and she went to all these doctors, and they put her on antidepressives, and they were very dismissive. They're like, well, you've got 5 kids, of course you're tired, right? And etc. And she tried the medication, but she didn't feel any better. So then she went to this sleep specialist, and he did a sleep study, and he's like, I bet you have sleep apnea. And she's like, I doubt it. And then she ended up having severe sleep apnea. And I think it was her age, whatever. And she didn't even believe it. She's like, how can I have sleep apnea? I feel fine. I sleep fine, right? And that's the truth. You're unconscious in your sleep. You don't know if you're choking even. Okay? You could choke 100 times and not know it. So that's what happened to her. So then she tried the CPAP, right? We all observe that the CPAP, BiPAP, AutoPAP have a near 100% success rate in resolving sleep apnea while you're wearing it. It's like something like 99.6 or some very high number. But they have a less than 50% adherence rate, right? For various reasons, it's uncomfortable. They feel claustrophobic, the air pressure, whatever, bed partner, whatever the reason is. A lot of people can't handle it, right? And so that was exactly what happened to her. She tried it all. What a great patient, by the way. What a trooper, right? And then finally, her sleep physician said, go see Dr. Shirazi and have an appliance made. So I made her an appliance, and she had an immediate result. She said the next day she woke up feeling refreshed, rejuvenated, ready to take on the day, was full of energy. You know, we did a sleep study. We got her down from 33 to like, I think 3. It was a huge,
wow,
huge
that
success.
is huge.
It was massive. It doesn't always happen like that. I just want you to know with an oral appliance. With CPAP, it happens like that all the time, but with an oral appliance, it doesn't always happen like that. And I'm very, very grateful. It worked. But it completely changed her life. And then she was just like, okay, you're right. It was the sleep that was causing my depression and my fatigue and etc.
Yeah, 100%. And sleep appliance, an oral appliance, does that kind of look like one of those guards, or what does it look like?
So if it's what we say FDA approved oral appliance therapy for sleep apnea, they're always going to be 2 pieces, top and bottom, and they're always going to be connected. Because if they're not connected, if you sleep on your back, your jaw can just fall back. That makes sense?
Yes, yeah. 100%. Have you heard of the Inspire that provides stimulation to the upper airways to facilitate breathing during sleep?
I have, and I'll explain why I'm skeptical, right? Yes. So, of course, they solicited me, and I know their data shows a definite improvement in sleep apnea. So I'm not denying that. I'm not denying that at all. So remember we talked about arousals? So we actually can measure that and call it an arousal index. How many times we're kicked out of those deep stages of sleep from REM and delta into something lighter. So the rep came to me and said, I want you to consider Respire, all your appliance failures and CPAP failures and all that. And I told them about my reservations about the arousal index. He goes, well, tell me what you want. I'll go get it for you. I was like, I need to see the before and after arousal index, right? So he sent me the before arousal index, which was very high, as expected. And then for the after, he gave me the patient's subjective arousal, right? How many times that, which is such a totally different number. You might as well ask me, you might as well show me like your blood oxygen and your EEG levels. They're so diametrically opposed. One is, subjective, one is objective. And I kept saying, I go, no, this is not what I need. I need the arousal index. He goes, well, I gave it to you. I go, no, the first one you gave me was an arousal index. The second one you gave me was not. I need the same thing as that. And he pretended like he didn't know what I was talking about. So that's why I'm skeptical. But if someone can show me a decreased arousal index with the Inspire, I'll be inspired by it.
I love that. I love that.
It is a surgery, and they do have to go in surgically. And if you lose the weight and you don't need it there anymore, then you have to have it removed, which is not easy. I don't know if you guys understand this, but you have to literally go and find your hypoglossal nerve. Without cutting it, you have to go and attach wires to it. And these surgeons, wow, I couldn't do it. Not that I would want to do it, but I couldn't do it. So. Yeah.
So what would be some if someone's so they do a sleep study, they've got sleep apnea, it's over a 5 an hour. What do they do? They get the CPAP, maybe. So if they went to a lab and got the sleep study done, the options they're going to be given is pretty much CPAP only. That's the reality of it. I'm sure it's the same in Australia as it is here. And that's an unfortunate thing. They
They may on the report mention an oral appliance, but very few sleep labs will say, "Oh yeah, you should get it because your AHI is only 15. You should get an oral appliance because we know you'll be compliant." Right? Someone with an AHI of 15 and is given CPAP only has a very poor compliance rate, very poor. People with severe sleep apnea are given CPAP or have a very high compliance rate. Right? So if they have mild to moderate sleep apnea, I mean, listen, I'm fine as a way of treatment. If someone says, listen, I know I have mild, but I can tolerate the CPAP, I'll be fine. Like, that's something I joke around in my lectures. Anecdotally, I've observed that people have already made up their mind as to what they were willing to tolerate before they've come in. Right? So I had a patient who came in, he was a fireman, and pretty much everyone in the precinct that he sleeps in the same house, right? They all wear CPAP. And he's like, listen, everyone else wears it. I'll wear it. If they can wear it, I can wear it, right? And sure enough, they didn't have to even try a second mask. He was fine at the first go, right? And then I have other patients that are like, look, doc, I'm a 40-year-old divorced man. I am not going to put that machine on after a date, right? But I will wear a retainer like a night guard, right? And that's just how it is. That's just the milieu, right? So, we offer that. We do inform them that, oral appliances are indicated for mild to moderate cases. Severe cases, you want to definitely look at a CPAP machine as your first line of treatment. But if you can't tolerate CPAP, even assuming you tried, an oral appliance is better than nothing.
Yeah, 100%. And that makes sense. That makes total sense. And I guess the thing is the compliance. That's the huge issue, like you said.
Yeah.
Because sometimes you got the little ones that you can walk around and take when you're going on a holiday and things like that. But some people aren't going to take them with them and going on a holiday. And that's probably when they need it the most, because they are drinking a bit more, they are staying up a bit more, they are eating a little bit more food and things like that, which I guess would make it worse in a sense. So it's the compliance that you want. That's the key.
Yes. Well, obviously, because what good is the device if you don't use it?
100%. 100%. I know we're coming to the end of the podcast, but I just wanted to put in here is that essentially individuals who are having that daytime fatigue that you mentioned, that depression, that anxiety, all those things, it actually may be due to sleep apnea. So would you suggest for individuals to get tested and see if they are sleeping properly?
Absolutely.
If they're having any of those issues. Is there any other issues?
Pretty much everything.
Yeah.
Pretty much everything. So
I was going to say that, but I was like,
inflammatory disease, pretty much every inflammatory disease, we can find a root in sleep apnea. It's possible. It doesn't mean everyone is. It just means that it's possible.
And there's so many individuals that have it and they just do not know they have it. And that's why I thought I'll bring you back on here again to talk a little bit more in depth about sleep apnea and just to bring awareness of it. So individuals, if they don't have it, their partner might, their kids might, someone that they know may have it. And if they get tested and they solve the issue for that period of time, how amazing is that? And it can bring a bit of better life, better lifestyle, better quality of life to them.
Okay.
Amazing.
Yeah.
Is there anything?
That's what we want.
Is there anything else that you want to put in and say to us about sleep or sleep apnea or about our health before we finish off the Natural Health Podcast?
Just please, if you're concerned, go get tested. If you're not concerned, but you have type 2 diabetes, high blood pressure, depression, anxiety, go get yourself tested. If you're thin, but you think, oh, it could never be that, go get yourself tested. Have the conversation make it normal to talk about your sleep with your doctor. I mean, a doctor's job before he prescribes a medication is to say, how are you sleeping? What's your diet like? What's your exercise routine like? What's your structural components like? Does anything hurt or pinched? or you have to walk with an impingement. If everything checks out, okay, great, here's a drug, you know? So, but sleep is like, they don't teach it in school.
And they should. It's absolutely, I love sleep and I love sleeping and I love the effect it has on our body. It's an amazing, if sleep came in a drug, everyone would be on it.
Yeah.
Awesome. Thank you so much for joining us on a Natural Health podcast. I really, really appreciate it. I'll put the links to your YouTube, to the testimonials that you mentioned. I'll put them below in the show notes. I'll also put links on where individuals can find you and if they have any to find you on your website and so forth, gather more information from there. So thank you so much for joining us on a Natural Health podcast. It's
my sincere pleasure. Thank you for having me again.
You're most welcome. Thank you for joining us on a Natural Health podcast. And remember, the missing link between failure and success is your health. Content and information provided here is opinion of Mahela Raguse and is for information purposes only and does not constitute medical advice. It is not intended to provide medical advice or take the place of medical advice or any current treatment you're undertaking. Consult your own medical professionals for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the Natural Health podcast. It is advised that you consult your doctor or healthcare professional in relation to any health concerns you may be having. Mahela Raguse does not take responsibility for any health consequences which occur from a person listening, viewing, or reading this content. And in the circumstances shall the Natural Podcast, Mahela Raguse, any guests or contributors to the Natural Podcast, or any employees, associates, or affiliates of Mahela Raguse be responsible for damages arising from the information provided on the Natural Podcast. By listening to this podcast, you agree not to use this podcast as medical advice to treat any medical conditions in either yourself or others. Please note, if you're taking prescription, do not stop your medication or start a new protocol, including but not limited to supplements, diet, lifestyle changes without consulting a doctor or healthcare professional. If you or any person has a medical concern, you should consult with your healthcare provider or seek other professional medical advice. Never disregard professional medical advice or delay in seeking it because of something that you have read or heard on the Natural Podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. Neither Mahela Raguse nor the publisher of this content takes responsibility for the possible health consequences of any person or persons reading or listening or following the information in the educational content.